by the end of my talk, so in the next 30 minutes, what I want all of you to take away from this discussion is why you should all care about iron deficiency anemia, when you should be thinking about this, and what you should be looking for, how you should be evaluated and treated. Let me bring up a couple of cases. These are both patients of mine that I saw earlier in clinic this week. The first is a 73-year-old woman. She typically gets nosebleeds 2 to 3 times a week. They last about 5 to 15 minutes, dripping in nature. Epistaxis severity score, which I'm hoping a lot of you are familiar with by now, was 4.06, primarily because she had a mild anemia. Her hemoglobin was 11.1 grams back in December. She's on tranexamic acid or Lystida 3 times a day, which works well for her. She tolerates it okay. And earlier this month, unfortunately, she had a severe episode of nosebleed. It lasted over 4 hours, pouring, and her hemoglobin dropped precipitously from 11.1 to 6.9 on the 15th of February. And along with that, by the day after her nosebleed, she was pale, short of breath, couldn't get out of bed. And I treated her with a blood transfusion. She also got iron infusions. And when I saw her in clinic 10 days later, her hemoglobin had improved to 9.4 grams. This is another patient I saw earlier this week, a 55-year-old woman, a yoga instructor, very active. She felt her nosebleeds were quite well controlled on topical estrogens. So it's topical estriol and petrolatum. She was applying twice a day, religiously using a humidifier overnight, was getting nosebleeds 1 to 2 times a week, lasting around 5 minutes, dripping in nature, and her epistaxis severity score was 2.43. She had, and that was primarily because she had mild anemia. Her hemoglobin was 10.9 grams in October. After that, I gave her an iron infusion and it normalized by November. Over the winter, as is not uncommon, her nosebleeds got worse and they had gotten to reliably happening 3 times a week. And she reported a few times a month she'll get nosebleeds that lasted up to an hour. And in clinic, she told me she had become more tired. She was struggling to complete her yoga sessions, but was still doing them regularly. She had started craving eyes, was having some difficulty sleeping, and her hemoglobin had dropped from 12.5 down to 9.9. And I highlight these 2 cases because I think it's important to understand that the symptoms that a patient may experience depends on the scenario, right? You can be, if you develop anemia rapidly because of major blood loss, what the body is going to feel is very different from if it develops gradually over time. And we'll talk a little more about that in the coming slides. So let's start with anemia. What is anemia? Well, as you all probably know, there are 3 types of cells in the blood. There's red blood cells, white blood cells, and platelets. Each of them have a different job to do. The job of the red blood cells is to carry hemoglobin, and it's the job of hemoglobin to carry oxygen and carbon dioxide to where they need to go. Anytime the number of red blood cells is low or the hemoglobin is low, we call that to be anemia. Here are some normal reference ranges for you. Men should have a hemoglobin of at least 3.5 or 135 grams per liter, and women should be above 12. This is very important, and the point I'm trying to make here is that anemia is a manifestation of an underlying condition. It's not a final diagnosis. Anytime somebody says you're anemic, that should be followed with a, here's why you're anemic, because if you don't know that, you're not going to know how to fix the anemia. So what are the different reasons why somebody could become anemic? So you can classify this broadly into, you can put it into 3 subgroups. It can be because we are losing blood. It can be because our bone marrow, which is the factory that makes all blood cells in the body, is not making enough red blood cells and hemoglobin. or it can be because we are destroying our red blood cells for whatever reason faster than we can make them. Here are some examples of each of these. Blood loss can be because of heavy menstrual bleeding. It can be because of intestinal bleeding or frequent nosebleeds, the last two scenarios which we most definitely see in the HHT population. Decreased production can happen for various reasons. I don't want to talk too much about this, but to point out that here, nutritional deficiencies is where deficiency of iron comes in, and that is a key cause of anemia in people who have a bleeding disorder. Other reasons could be anemia because of coexisting medical disorders. Certain medications can cause anemia as well. Chronic kidney disease is well known to cause anemia because the kidneys are what make EPO and erythropoietin, and that is an important hormone that drives the bone marrow to make red blood cells. And finally, you can have primary bone marrow disorders that can develop as we get older that can cause anemia as well. If you look at some of the causes for increased destruction of red blood cells, what we call hemolysis, this can be because the immune system decides to fight our own red blood cells by making antibodies against them, what we call immune hemolytic anemia. It can be because of other changes in the body, what we call non-immune hemolysis that can happen in certain types of disorders, including defective heart valve function, where as the blood passes across a defective heart valve, it gets chewed up. And we can also have increased destruction because we have abnormal red blood cells, what we call hemoglobinopathy, sickle cell disease, that a number of you may have heard of, is a common cause of that, where the red blood cells don't live the normal 100 days that they're supposed to. Okay. What would you feel if you had anemia, right? What are the manifestations of anemia? You can look at this in subcategorized in a few different ways. First, the response to just having lower amount of circulating blood can be a fast heartbeat as the heart tries to compensate to make sure that blood is flowing to all of the places it needs to go. It can be manifestations related to a response to losing a lot of blood in a short period of time, like the first case I presented today, what we call hypovolemia. And there you can have a drop in blood pressure to the extent that some people may pass out because of the amount of blood they've lost. And also go into what we call shock because of poor circulation and blood not getting to all of the tissues it needs to get to. And you can also have manifestations related to not getting enough oxygen to the tissues, weakness, fatigue, shortness of breath, which is walking around the house, headaches, not being able to tolerate exercise are all manifestations of not having enough oxygen. So let's talk a little bit then about iron. We've talked globally about anemia. Let's bring it down to the level of iron. Why do we need iron? Iron is an essential part of a lot of things in the body. It's not just red blood cells and hemoglobin, although the majority of the iron in the body is in hemoglobin. It's also in the muscle in the form of myoglobin. It is also an important component of certain enzymes and a part of our immune function. So we need iron for a lot of things. Now, how much iron do we have and where does it live? If this is a representation of all of the iron in our body, and we have about 4 grams of iron in an adult, 2.5 of those grams is in hemoglobin. About 1 gram is put away for a rainy day, it's in storage. And another 0.5 gram is in muscle and in all of the other functions I mentioned, immune, enzymes, etc. Now, how do we meet or regulate our iron needs? It's important to understand that the body does not make iron. It's entirely dependent on our diet to get the iron that it needs. And for that reason, too much iron stored in the body is also not good. And the body regulates our iron needs very closely. It only takes in what it needs so that we are in net neutral iron balance. Per day, we need about 1 to 2 milligrams of elemental iron. And the recommended daily iron intake is about 8 to 18 milligrams. And that's because we only absorb about 10 to 20% of the iron we have in our diet. There are some such special situations where people need more than this 1 to 2 milligrams of iron per day, and those are listed here. If you look at the sources of iron, you can broadly split it into heme iron, that is in red meats, liver, egg yolk, fish, so animal-sourced iron, as opposed to non-heme iron, which is plant-sourced iron, fruits, vegetables, grains. Uh, the vast majority of the iron in our diet that our body gets comes from non-heme sources, so plant sources, and only a fraction of it is animal-sourced. Now, when you talk about developing iron deficiency, it typically happens in stages. And this is important to understand because if you get this, then you understand why a lot of iron deficiency gets missed. If this is a depiction of normal state where you have all of the three different silos in which iron lives in general. Now, if we start having excessive bleeding, whether it's nosebleeds or GI bleeding, or we stop taking enough dietary iron because we're exploring a fat diet. This is what will first happen is once iron stops coming in our diet and the body stops getting iron, or we start losing a lot of iron by bleeding, we tap into our rainy day fund, right? We tap into our stored iron to try and maintain our hemoglobin and keep pushing iron to all of the other areas it's needed. If this continues and we still don't fix the problem, then what's going to happen is we run out of our storage iron. And then still the body is conditioned to protect the red blood cell hemoglobin compartment and preferentially deplete the other compartments. And so this is a stage where you would develop iron deficiency, but still not be anemic. But you will have other manifestations of iron deficiency. You may have a craving for ice, constantly keep chewing ice, feel achy because your now myoglobin pool is affected, your muscles don't feel so good, you don't have a lot of energy, fatigue, you can't focus. And so all of those manifestations, so you feel worn out, you go see your doctor, you tell them, I don't feel so good. And they do a CBC and tell you, hey, you're not anemic, your blood counts are great. But if they don't look for iron, they completely miss that there is a problem and there is a very clear explanation for what you're feeling. But then you get advice as to, hey, just take it easy, go rest. Or some people will tell you, maybe you're deconditioned, go work out more, which is impossible for you. And it's only after all of this that you will ultimately end up with anemia, which oftentimes is not a diagnosis that is missed. It's the iron deficiency without anemia stage that tends to get missed. And bear in mind, this typically develops over time unless you're having massive bleeding. Okay, how do we make a diagnosis of iron deficiency and anemia? Clinical suspicion in a person who has reason to have it is important. Typically, we make the diagnosis based on blood tests. We get a complete blood count, look at a blood smear, and a complete blood count tells you, I'm sure all of you are familiar with it, tells you what the white blood cell count is, the red blood cell count, hemoglobin, hematocrit, platelet count. We look at a blood smear that has very classic findings that would be consistent with an iron deficiency picture. And then we measure iron levels, ferritin and an iron panel. Ferritin is a good workhorse to rely on because a low ferritin is always iron deficiency. There's no other reason to have a low ferritin. A normal ferritin can trip us up sometimes because ferritin is what we call an acute phase protein. So if you're under a lot of stress, have inflammatory processes going on, then we would have a ferritin that's falsely normal, even in the setting of iron deficiency. And that's why I've put here that you also have something called an iron panel that you can check in addition to a ferritin that will help you in those situations. So that's how we diagnose it. How do we treat iron deficiency anemia? First line treatment is always oral iron. And this again can be either oral iron that is from a heme source or a non-heme source. Non-heme is the most common, and I'm sure you're all familiar with all of these products that I've put up here. The most important thing to remember here is non-heme sources tend to have a lot of elemental iron in them, like your ferrous sulfate 325 that you get over the counter has 65 milligrams of elemental iron, which is a good amount considering you only need 8 to 18 milligrams a day. The problem with that is also the more elemental iron in our diets or in these supplements, the more your risk for side effects, and those can be nausea, bloating, reflux, constipation. Heme sources are fewer in terms of products available, but tend to have lower elemental iron, and probably for that reason tend to be absorbed better and tolerated better. Okay. Here's the most important thing to remember with oral iron replacement. Yes, a healthy diet that is rich in iron-containing foods is important, but eating red meats, liver, oyster, spinach 3 times a day is unlikely to make a huge difference. And the reason I say that is because there is a cap to how much iron you can absorb in your intestines. You can have a gram of iron in your diet every day. You're still only going to absorb 10 milligrams. The other 990 milligrams are going to come out, and in the process, you're going to feel miserable. So that's important to bear in mind. Some of the factors that affect dietary iron absorption, like I mentioned, heme iron is better absorbed in the diet than non-heme iron. And there are certain things that will interfere with iron absorption. Calcium is a big one. So don't pop your iron pill with a glass of milk. You're probably not going to absorb it very well. Phytates, like in bran oats, so breakfast cereal, can interfere with iron absorption. Tea as well can. So it's best to take iron on an empty stomach if you're able. And increasing the acidity in the stomach will help iron absorption. So vitamin C taken with iron can help it. There are a lot of products that club vitamin C and iron together in one pill. Or you can just take it and wash down your iron with a glass of orange juice like most people do. Some of the reasons why oral iron treatment may not give you the response you're looking for. Most common that you're not taking it. 50% of people that are prescribed oral iron don't take it because it makes them feel bad. There are other reasons as well. There may be other reasons for anemia that is not iron related that should be kept in mind too. Poor absorption can be because you're using coated pills, other coexisting disorders, which can either be because you had intestinal surgery, malabsorption, or other medications that interfere with iron absorption, all of which can be a problem. But the most important thing to keep in mind is ongoing blood loss, particularly in our HHT population, right? And if you're bleeding more than I can replace with oral iron absorption from the intestines, then this is not going to ever be caught up with. So then the alternative, if we can't do oral iron, is to do intravenous iron. When would we consider intravenous iron? You consider when you don't tolerate oral iron or you're losing more blood than you can reasonably catch up with oral iron replacement. The advantages of intravenous iron are you can do a large amount of elemental intravenous of iron replacement intravenously in one sitting. It's reliable. You don't have to worry about the diet or absorption, and you don't have to worry about the GI side effects. The disadvantage is it's more expensive. It takes time. You need to go to an infusion center to get it. For the first day or two after you get an iron infusion, there are some side effects people may experience. Aches and pains, headaches can happen. And rarely there is this reaction that can happen. More commonly, people can develop non-severe, non-life-threatening reactions, which we can deal with by giving them an antihistamine or pre-medication with a small dose of steroids. Life-threatening reactions are rare. Here is a table that I've updated now because there is a nucleid in the block, so to speak. Monoferric is now available. So we now have 6 different intravenous iron preparations that we can use. Their primary difference is in the third column, which is the amount of iron per dose that is given, as well as the fourth column, how long it takes to give them. Different places use different products. No one is better or worse as long as people are understanding of how much they're replacing per dose. Because with some preparations, you may only need 1 or 2 doses. With other preparations, you may need a lot more to meet the goal. Okay. Now, specific to HHT, what are things to remember in terms of iron deficiency anemia? 50% of people with HHT have anemia. Okay. So this is a common problem in HHT. Iron deficiency without anemia can be symptomatic. People can develop fatigue, muscle aches, restless leg, hair loss, and decreased attention span, more so in children, but probably in adults as well, right? And not to mention pica, which is the craving for ice, craving for starch, craving for clay. I've seen a lot of those. Um, Bear in mind, iron deficiency is frequently missed in the HHT population because the iron part of it is not checked. While anemia may not be missed, iron deficiency without anemia is, I think, frequently missed because people are not on top of it. And treatment of iron deficiency with or without anemia is an important component of the care for somebody with HHT. Now, what I want to close with here, and I think we'll have plenty of time for question and answers, is highlight the HHT treatment guidelines that were recently updated. We made, as part of these guidelines, 4 recommendations that are specific to iron deficiency and anemia as part of this larger anemia and anticoagulation recommendations. The first one was a recommendation that says that all adults, regardless of symptoms, all adults with HHT should undergo screening for iron deficiency and anemia. In terms of children, all children with recurrent bleeding or who have symptoms that could be consistent with anemia or concerning for anemia should also undergo screening, right? And there was widespread agreement. Everybody agreed with this evidence or with this recommendation. And in terms of, and I won't go into what's written in the bottom, which is the clinical considerations, which just covers what type of tests should be done and how we should go about it. Now, the second recommendation was with regards to treatment of iron deficiency and anemia, where the recommendation is initially that everybody should get oral iron, and that intravenous iron should be considered in people in whom oral iron is not effective, not absorbed, or not tolerated, right? Another recommendation is also if upfront you're presenting with very severe anemia, then intravenous iron may be considered as first line instead of trying oral because we just have so much to catch up on. And again, there was a reasonable amount of agreement with these recommendations as well. Now, let's talk a little bit about follow-up, okay? So you start somebody on treatment with iron, whether it's oral or intravenous. What follow-up is needed? We are recommending a CBC and a ferritin monthly if there is ongoing bleeding. And 1 month after initiating replacement of iron, a CBC should be checked to assess the response and should also get a reticulocyte count, which is essentially a test that measures how many baby red blood cells or new red blood cells are coming out of the factory, the bone marrow. And so that would also tell us whether you're appropriately responding to the iron replacement. And if the hemoglobin has not responded or increased by at least 1 gram 1 month after oral iron, that may be a time when we consider intravenous iron because we're not having the response we'd like to see, maybe because we're bleeding more than we can catch up with just on oral iron, or we're running into absorption issues. We want to continue some form of regular ongoing iron replacement to maintain the stores. And in patients who are requiring intravenous iron, the goal is also to be proactive and stay ahead of the bleeding, right? It's not one and done. It is constant reassessment and replacement as needed. Okay, the third anemia recommendation was regarding who gets red blood cell transfusions. Some of the conditions have been listed here. People who have lost so much blood that they are hemodynamically unstable, meaning their blood pressure is low, they're not getting enough oxygen, they're in shock, they should get transfusions. People who have comorbidities that require a higher hemoglobin target. By that, what we mean is supposing somebody has either an HHT-related problem such as heart failure, or they have other heart failure for non-HHT-related issues that require them to be at a higher hemoglobin because they don't tolerate living at a hemoglobin of 8, and they need to live at 10. Situations like that, if the hemoglobin falls below the target, they should be transfused up to their goal. And also, if you need to increase the hemoglobin acutely, such as somebody who's pregnant, who is in the third trimester getting to delivery, we don't want the hemoglobin to be 6 or 7. We want it to be higher. We should transfuse them. Or prior to elective surgery as well. The higher your hemoglobin, the closer to normal that you go into surgery, the better your outcomes will be. And also, if we are unable to maintain adequate hemoglobin despite iron infusions, then that may be a reason to transfuse the patient. Okay, so that's in terms of who gets transfusions. And the last one is also more of a reminder to people not to forget, to keep in mind that anemia has many different causes, and iron deficiency is only one of them. So bear in mind that anemia could be due to something that's completely not related to iron, and if you don't look for it, you don't find it. So that's something to keep in mind as well. So those were anemia-specific recommendations from the guidelines. So my last slide here, my take-home points. Remember that anemia, because of iron deficiency, is common in HHT. And even if you're not anemic, you can be symptomatic from iron deficiency. All HHT patients should be screened for iron deficiency and anemia regularly. An aggressive correction of the iron deficiency will improve a person's quality of life. And be familiar with these HHT treatment guidelines. Share them with your medical providers so that we're all on the same page. And with that, I'll stop there. I'm happy to take questions. My email address is here. If you have questions, feel free to reach us, either email me directly, or there's a lot of resource on our webpage as well. Thanks again.
All right.
I will give you back the screen.
Oh, thank you.
If I can figure that out, unless you can take it yourself.
Let me see here. Yeah, I can do it. Oh,
good. Thanks.
Perfect. Okay, thank you so much, Dr. Kasthuri, for such an interesting and engaging presentation on an extremely important topic. So our first question is going to be on clotting, and that will be split into 2 parts. So what is the relationship between HHT and blood clots? And is there an additional risk in taking medications like anticoagulants or blood thinners?
Yeah, so great question. The second question is easier to answer than the first one, so I'll do that. In terms of HHT and blood clot, let me answer that first. We don't know if there is a relationship between HHT and blood clotting. There are reports that people with HHT have a higher prevalence of clotting compared to the general population. And, but we still need more work to try and figure that out. The best evidence we have is from a single center in Europe. We are still working on learning more about it. So I don't know is the answer, but we are working on figuring that out. The second question, blood thinners and HHT, it is a problem going on anticoagulants in a primary bleeding disorder, right? Because the fear is we're going to bleed more, whether it's nosebleeds or GI bleeds. But at the same time, if you've got an acute clot, if you don't treat it, then that's a problem too, because that can lead to life-threatening complications. The way we approach it, and in my experience, blood thinners. So when you think about blood thinners, there's 2 broad classifications of them. You can have blood thinners that are primarily antiplatelet medications, aspirin, Plavix, and the naturopathic variants of that, ginkgo, St. John's wort, vitamin E, fish oil capsules. All of those essentially prevent platelets from sticking to each other and cause clotting. And because HHT bleeding happens from mucosal surfaces, the lining of the nose, the lining of the intestinal tract, platelets are very important to prevent bleeding or stop bleeding in HHT. So antiplatelet treatments are very difficult in HHT and almost reliably will cause bleeding. We are able to, on the other hand, do anticoagulation, heparin, warfarin or Coumadin that people may have heard of, Eliquis, things like that, that don't target the platelets, but target the clotting proteins are probably better tolerated in people with HHT than the antiplatelet treatments are. So it is long-winded answer to it can be done. It needs to be done carefully, and there may be certain types of blood thinners that are better tolerated, and somebody who understands that should be involved in the care of anybody who needs blood thinners in HHT.
Okay, thank you. The second question is, can vegan diets work well for HHT patients who have iron deficiencies?
What diets? Any diets, or was there a specific diet?
Yeah, sorry, vegan diets.
Yeah. So the um, thing to remember is there are iron-rich plant sources, right? So yes, vegan diets can help, um, but it all depends ultimately on how much blood loss we're dealing with, because any diet, as I tried to point out, will only go so far if you're bleeding a lot. If the bleeding is not a big problem, then yes, there are fruits, grains, and plant sources that are rich in iron that you can lean on. And it doesn't always have to be meat source. Yes.
Okay, great, thank you. So we have quite a few more questions actually. So another question, split into two parts. So is there a difference between getting a serum iron blood test or ferritin blood test, i.e., do they tell you the same thing? And should HHT patients only get ferritin blood tests?
Yes. Yes, so the serum iron is different from the ferritin. Ferritin is a reflection of the body's iron stores. Serum iron is more a reflection of how much iron is floating around in the blood. Okay, so they tell us different things. If you were only going to get one test, get a ferritin. And that will tell us what we need to know, because, like I said, a low ferritin is iron deficiency. We're done. We don't need to do any more testing. We need to start treating. Um, the serum iron would be helpful in people in whom the ferritin is not reliable because they have other disorders, inflammation, things like that, that can actually falsely elevate the ferritin. Um, and this is the same thing that we've covered in the guidelines as well, to say go with the ferritin as a maintenance. But if you're worried that the ferritin is not giving you a reliable answer, then you can get what's called an iron panel. And that consists of a transferrin saturation, a serum iron, and a total iron binding capacity. Those are the three tests in an iron panel. And they can all help us when we question the ferritin.
Okay, great. So the next question will be, how is copper involved with iron absorption?
Copper. So copper is not directly going to bother your iron absorption unless you're taking copper supplements and iron supplements at the same time. They can compete for absorption. It's not something that we see frequently. And copper causes a completely different, copper deficiency causes a completely different type of anemia to what iron does. And more frequently, we worry about copper interfering with zinc and not so much iron. If you're taking both the supplements, I would recommend you take them at different times.
Okay. And another question, should HHT patients avoid NSAIDs and ibuprofen?
Yeah, so NSAIDs as a class is either ibuprofen, Advil, Aleve, naproxen, all of those things are NSAIDs, non-steroidal anti-inflammatories. They're like aspirin. They are used for their anti-inflammatory effects and as painkillers. And the problem is they all have antiplatelet effects. And my recommendation to my patients is if you have a really bad headache and Tylenol is not working for you, it's okay to take ibuprofen. If you take 1 or 2 doses of ibuprofen, it's not the end of the world. You'll be okay. It's the people that take ibuprofen 2 or 3 times a day for 3-4 days in a row that will be a problem. You will notice not doesn't happen in everybody, but the risk is that the nosebleeds or the GI bleeding may get worse. So that's something to be careful about. But again, the struggling with a headache that won't go away is not great either. So it's okay to take it, once in a while. Just don't do it regularly.
I see. Okay. So next question will be, is there a step beyond IV iron therapy? Is there a limit to how frequently you should receive IV iron?
Yeah. So there isn't, and this is a frequent misconception. If you are low on iron, then you need more iron, then you get iron intravenously is fine. There isn't a, you're not going to make somebody who's got a primary bleeding disorder iron toxic by giving them iron infusions, because then you wouldn't be iron deficient with anemia in the first place. Does that make sense? So you can put in as much iron as you need to, as long as what you're treating is iron deficiency and the patient is indeed iron deficient. How frequently can you get it? We give patients iron a couple times a week if we need to. That's more a function of convenience for the patient, which is where there are advantages with products that you can get away with a lot of iron in one sitting. It's more convenient for the patient. They don't need to keep coming in twice a week or every week for a month to get iron. If you can do all of that in one sitting, and there's no downside to that. You can give 2 grams of iron in one sitting, and it doesn't have to be capped at 500 milligrams or 1,000. That limitation is more a limitation of the product, not what the body can handle. There are some products that you can only do X amount at a time because that's how they're labeled, that's how they're approved, and therefore you can't get it and do it any other way. Um, but there are other products that don't have that cap, and you can give as much as you need.
Okay, great. Next question. How many days do we discontinue oral iron before getting tested?
If it is oral iron and the test we are getting is ferritin, oral iron replacement will not affect your ferritin, right? Because ferritin is storage iron. Oral iron replacement will affect your serum iron, will affect your transferrin saturation. And so you probably don't want to get those labs done if you're on daily oral iron. Certainly just after taking the pill, if you go and get your blood test, it may be an issue. So in those settings, maybe discontinuing it for a couple of days and getting your iron test would be good. But if all we're doing is a ferritin, it shouldn't be a problem.
Okay, great. One more question. Maybe we have time for 1 or 2 more questions. So the next one will be, as a machinist working with lead every day, we do receive regular lead monitoring. Can someone explain the link of lead exposure to anemia, and can it be more serious for people with HHT?
Very good question. So lead poisoning or lead toxicity causes a type of anemia that's more along the lines of sideroblastic anemia. It's a little different from iron deficiency. And the only risk specific to HHT will be, now you've got 2 reasons to be anemic, not necessarily interrelated, but you've got 2 completely separate reasons for being anemic. I'm glad that they're monitoring the lead levels. That's great. But outside of that, that shouldn't have any bearing on your HHT.
Okay.